now. Okay. Well, hey, thank you for joining us for another high tea. I hope you've all brought your coffee or your tea along, and I haven't got my silverware out again, but I like to keep a lid on things in the office just in case I have a bit of an accident with my coffee. But anyway, so thanks for joining us. Now, what we're going to do is we're going to look at some of the questions that I have been emailed privately since the EMS presentation last week, and I'm still waiting on the full set of questions, and apparently there's lots of them, so I will do another production, or I don't know, something like that to get those answers. I'm much better at speaking than I am at typing, so that's why I like this kind of format. For those of you who are joining us, if you do need to jump in and talk, please do, okay? So one of the questions was sent to, well, a bunch of questions were sent from one girl who's working and wanting to use silver fluoride, and she wanted to first of all find out what recall do I recommend after the first application. So when you're using silver fluoride, it's very case specific. When I'm using the first application, it really will depend. I like to at least have that in about the first month to 3 months. Now, the reason why, that's if I get a good 3-minute application followed by the stannous fluoride and then the Durafat. If it was an interproximal remineralization, then I'll happy to just check that at the recall period, because I would have educated the families on flossing and you know, regular care and things like that. If it was an open caries lesion, then I would get them back within about a month. And if the and then that will assess the arrest, because following the ARMA approach, I want to make sure that the caries has arrested, and I want to ensure that the colour has changed and that the symptoms have resolved. So if it's if it's just an open caries lesion, then I like a month, between a month to 3 months. And then also they're following up with the correct, you know, this bit don't rinse, and we're trying to get as much other fluorides into there as well, just naturally occurring calcium phosphates and fluorides, particularly if they're in a fluoridated area. That is different if it's a hypermineralized tooth. If it's a hypermineralized tooth, I like to get them back around about 2 weeks later, because oftentimes they're going to need that will need that second application if the tooth is quite open and broken down. Now, the reason why is because they're so sensitive that getting a really good air drying on those teeth is near impossible the very first time. So you do the best you can and you get the application on, but that significantly decreases their sensitivity, so that when you get them back again, you can actually puff some gentle air on there and get a really good application the second time round. So does that answer the question for those who are here today joining us?
Yep.
Yep.
Okay.
Sounds good.
Okay. So the next one was, what clinical presentations indicate to you another application is necessary versus restored? Okay, clinical presentations would be if the symptoms have disappeared, if the tooth looks like it has arrested and remineralized, and that you tell by the blackness, then if I was wanting to restore it, then I'd go and do that at the second visit. And I like to have that second visit between, I like to leave it about 2 weeks. Sometimes I can only leave it a week, but 2 weeks or plus. Now, as you've seen in some of those cases, particularly the one that we did last time, one application, sometimes I don't get to see them for 3 or 4 months, and that's fine. Again, not excluding the hypermineralized scenario. But the other thing too is it depends on the age of the patient. So if I'm putting this on a little 2-year-old and I'm not going to get great remineralization, I'm going to get great remineralization, but I'm not going to get a great restoration done, I'll just repeat it. I'll check it in a month, and then I might do that at the 6-month mark or whatever. As you go through this, you'll learn what is the best course of action for your particular patients. But there's no right or wrong. Silver fluoride, you've got to remember, was invented to be put on, and then you didn't have to actually ever go back and restore the tooth. That was the original intention, because we didn't have white fillings that could go on there. And the intention was that you actually put that on the tooth and left it. So if we look at that mindset, it's okay to do it, but it's also okay then to go ahead and do a complete restoration. I would only do a second application if there were symptomatic reasons for it. So if you were losing the blackness and there was a little bit of brown coming through, that means that there was a resurfacing of the bacterial activity. Now, I've only ever had that a couple of times, and one recent application, which, you know, I usually have like 100% success and everything's arrested. But this particular case, this little girl had a 5-4 and a 6-4 with those kind of really deep lesions on there, on her occlusal surface. There was nothing interproximally. But when I got her back, it was almost as like I hadn't put any silver fluoride on there. And then we started talking about diet. And I said to the parents, okay, this is really unusual. I need to start looking at your diet. Well, it turned out that what she was having for breakfast was, she was in a difficult, she had just come from a very poor family situation. Okay, so she was now into, you know, she was now back with another parent, and she was in a much better situation than what she was the first time for all her young 4 years of age. And so, but they were slowly changing the way her diet was changed and things like that. So she was actually having Nutrigrain with sugar and honey for breakfast. And so, and basically a very, very highly kerogenic diet. Now, you would think that that would be stupid and nobody would do that, but this is what the parents were dealing with. Now, moderating that diet, nothing was going to make that diet and the tooth less kerogenic until we addressed the diet. So I was actually still able to fill those teeth. There had been some remineralization, but the brown was still very much there. So we needed to really work on that. That's really unusual, but it's the visual of what you're seeing. So if it stays black, you know it's arrested. And that's why CSDS is called caries status disclosing solution. I knew darn well when I saw that child that her caries was still active. Okay, the second one was, how many applications do you recommend before a restoration? In general, it's one. One is usually all you need. I hardly ever have to put a second application on unless it's a deep permanent tooth sometimes, and definitely for a hypermineralized tooth that has got post-eruptive breakdown. So the rest of them, I can put it on and then get them back. Okay. Got somebody else joining us there. That's nice. Alrighty. So the next question was, how do I handle, now this is a bit tricky, okay? How do I handle dentists treating the art technique as substandard or judging your x-rays, saying you left decay and were adamant that every single last bit of decay must be removed prior to placing a filling, even at the risk of pulpal exposure? That is really difficult. Now, one of the things you have to understand when you're using silver fluoride is that if you are putting silver fluoride on and you have achieved the blackness and you're able to restore that tooth, there is no decay. Decay is a process, caries is a process, and it's an active process. What you have done is you have stopped that caries from progressing and you've killed the caries because you've taken care of the bacteria. Then what you've got left is the dead cells and the broken down collagen, which has been remineralized. You're taking that blackness out. the bit that's left underneath the filling is not caries, and your dentist needs to be educated somehow in this. Okay, it's not caries, it may resemble caries, but it is not, because it is remineralized, remineralized and solid dentine. And so the remineralization has occurred when you go down and you take that all out, and when you're actually taking off the burnt toast, and then you get that hard stuff, you are not ever going to get deep like you would be if you were chasing active caries. So you are going to stay further away from the pulp tissue. And when you go and put a restoration on top of that, you can call it a smart filling if you want, which is a silver modified atraumatic restoration technique. But it's not a temporary solution, whereas an art technique in the true sense of the word was to try and buy time, get some remineralization, and it could well have been a permanent situation. But I was never a believer in the art as a good technique. It sounded great, but I had seen too many fail over the years to actually adopt it myself. So I was a do it once and do it right person, and I would be putting composites in and giving LA and doing it really well. This has changed the way I do things now, because I am way more conservative now, but not, what would you call it? It's more conservative to the tooth, but it is more, it's not as aggressive in the treatment. So you're actually saving tooth tissue. So the education of your senior clinician, if they don't get this, basically has to be, bring them in and show them what you're doing, I'd say. Show them how hard it is, that just because it's discolored, they will actually see and they can hear the cryogenic themselves, and that might begin to change their mind. But x-rays, you need to, and we've got a couple of, on the Black Diamonds Rock website, we've got a couple of pictures where you can actually see where the actual caries lesion, it looks different from active to arrested. And I think that's probably, showing them those comparisons is probably a really good idea in that situation. I have had in the past, which did my head in, I had a beautifully arrested tooth. I put a GIC in there, which was lost. Another dentist in our same practice got it, and they did then, on top of, instead of just, because it was all very arrested and it had the GIC, so you can imagine how hard it was, drilled down, did took all the brown stuff out, and of course then put a lovely composite restoration in, but yeah, exposed the tooth, and it came back and it had an abscess. And I'm going, what's going on with this? When we looked at all the history and then the x-rays, I could see this beautiful box restoration that had gone probably another millimetre closer to the pulp tissue than what my restoration had done on solid tissue. And so they were chasing the white. So it's really a thing where you've got to educate your clinicians that you're working with. Yeah, it's one of those, until the dentists learn how to do this and learn what they're doing and learn to accept that this is really a very conservative treatment, and it's not a substandard treatment, it's conservative and very acceptable, and particularly acceptable to kids and to parents. Anyone got any comments or questions on that so far? Nope. Okay.
No, all good.
Okay. The fourth question was, is the product indicated for interproximal enamel lesions or in the enamel lesions in general occlusal? In other words, yes, you can use it in enamel. Okay, it doesn't have to be into the dentine, because any tooth tissue that has been demineralized can be remineralized. A lot of times, traditionally, they say once you get it into the dentine, you can't remineralize that. You're going to have to remove the affected dentine. So silver fluoride will remineralize dentine and enamel. Any part of the area that has been demineralized and has been affected by that caries process is more likely to stain black. If it was just early demineralization, oftentimes you don't get that staining of the black. But if it was, then yeah, but you definitely can. And a lot of people, Christine, was it you that were using it before you're doing fissure sealants?
Yeah, we're looking at doing that. Yep.
Yeah.
Rather than those stained sticky grooves and pits, rather than drilling them and using a flowable composite.
Yeah.
To use the silver fluoride and then maybe a GIC seal over the top.
Yeah.
Because it's more opaque.
It's more aesthetic.
More opaque.
Oh, more opaque. Yeah, that's true. Yeah. But that will be, on a permanent posterior molar, even if there was a little bit of staining down there, once you've got those good nodes, you are doing the tooth a favour, because the next clinician that goes along, if they pick up a burr and they go into that tooth, that's where the process is going to fall down. So yeah, definitely for interproximals, it's awesome. One treatment interproximally, sometimes, and I've got 20 plus month follow-ups, that was, probably be 24 months now, where there's been just no change. The ones where I have had the tooth progress interproximally has been where the diet has been shocking and the parents have not insisted on good oral hygiene processes. And I had again another little fellow and his did progress, but it progressed so much in 6 months that I had to I looked at the x-rays and then I looked at the following, I don't know whether it was 6 or 12 months, but it was just massive, the progression of the caries, even though I had treated it with silver fluoride. And I had to say, okay, folks, this is really unusual. What is happening at home? What is the diet like? Because this is not normal. It's not normal if the diet is good, if teeth are being flossed and they've been using, a fluoride toothpaste. And apparently this little one had free access to the snack cupboard, and it was full of, muesli bars and, fruit bars and all of that kind of stuff. Now, Dad was right on board with the diet. Mum, but he was a fly-in, fly-out worker, so he was gone, a week at a time. I think it was Mum's coping technique, mechanism to just sort of go to the cupboard, eat what you want. So the whole family's diet changed around. He had had 2 teeth extracted in the past because of interproximal caries going to the pulp tissue. We had then applied the silver fluoride, trying to slow or stop the rest. But anyway, in the end, what we did is we put silver fluoride on these very active lesions, and we got him back and we filled them up, and the whole family dynamics has changed around now because of that. But he was a highly anxious little boy. The first extraction that he did was horrendous. I think it was infected. Nobody had waited for the LA to work before they took out the tooth, or it was so infected that the LA did not work. So it basically ruined him for the next practitioners that came along. But it happens like that, especially these days when they don't hand out antibiotics very much. Back in the old days, we used to give them antibiotics if there was any element of infection in the tooth, settle that down, get them back a week later, the LA would work really well and we'd have no problems getting it out. But I think it's where there's infection and the LA is not working well, we lose a lot of kids that way. I don't know if there's any long-standing clinicians that can agree with that, but it's just the change in the way we're using antibiotics. All right, what clinical situation would contraindicate the use of this product? Clinical situations to contraindicate would be if the parents did not, after being shown the pictures, did not want to have any bar of that will be one. If you had somebody who was allergic to silver, which is very, very unusual, and most people don't even know that until they get exposed to it, especially if they're looking at children. And also if there's some ulcerated gingiva that's already there, obviously that wouldn't do. It's particularly important if you're using a material that has got the ammonia in it. Definitely steer away from that. But that kind of thing is the only thing. Now, clinical situations would also be if there is a irreversible pulpitis, definite irreversible pulpitis situation, because it's not a miracle worker. But if you've got any concept that this may be reversible because your clinical questioning has not brought up pain at night, or you know, if it's pain on eating, you have to work out whether it's pain on eating because of food impaction, and in that case I will then give that a go. I'll look at the x-ray last. I will look at the tooth after I have done the whole questionnaires, because the clinical indications with our eyes don't match up with what is often happening in the tooth. And I like to give the tooth the benefit of doubt. And I cannot tell you the amount of times that I have been extremely surprised at how well that that reacted. If you remember that fellow that I did on the webinar last week, most people would have gone straight for you know, a root canal, or you know, condemned that for a to much more invasive treatment. But by just listening to the symptoms and treating the caries and managing the situation the way we did, really, really good outcome for that young fellow. Now, another question that I've got sent to me is it safe to use on breastfeeding mums? Now, if fluoride is safe to use on breastfeeding mums, then this would be safe to use on breastfeeding mums. You are doing it site specific, and you're using a tiny amount. So if you were going to have a breastfeeding mum, and to be honest, I don't treat very many breastfeeding mums because mainly pediatrics, but if you're going to put a fluoride treatment on a mum, and she, like whether it was Durafat or you know, one of the gels, you're going to risk a much higher exposure to the fluoride than what you would do if you were using, you know, a spot application of silver fluoride. So yeah, so that's what I would be guided by, the fluoride. The silver component is so tiny, I doubt very much that would actually be a contraindication for a breastfeeding mum. And they say all the time, you know, don't do this if you're breastfeeding, don't do this. You know, half the food in the world they say don't use if you're going to be breastfeeding or you're pregnant. It's just, and I'm not being silly about that, but if you go into the States and you go to some of the burger joints, they've got stuff on the wall that says some of the ingredients in some of our burgers, you know, have to have a warning on them to say that they can't, that, you know, that breastfeeding mums should be careful, or pregnant mums. So it's just, you know, that's nothing to do with soft cheeses and things like that. Are there any other questions?
No, so far so.
So far so good. Okay. I'm the breastfeeding mom, and I have sensitive sticky fissures. Yeah, I think Bree, if that's you, and it's a couple of teeth, I think that would be fine. You're mitigating it. Just whoever's going to use it, get them to use just the tiniest bit on a tiniest micro brush, because it's only the fissures. Okay, pop that down. Sorry. Okay. Get them to put that down down there, and then just you know, put the Durafat over the top. You wouldn't even need to do the stannous if you didn't want to. Okay, just get the silver fluoride down there and put some Durafat over the top. The reason why I'm saying if you want to sort of minimize your fluoride intake that way. This is my daughter-in-law, sorry. Hang on, I'll just quieten it down. Yeah, so that's what I would do. Does that sound okay to you, Bree? Okay, yep, it does. Alrighty. All right, so if there's no other questions, what we'll do is we'll end this now, unless anyone's got anything else to say. You know, another question? Yep.
Just I was just going to say, so if you don't have to use the stannous solution, like say, for example, if people are really worried about having the fluoride on interiors and they don't want it to turn black, could you just use the silver fluoride without the stannous?
If you didn't want it to turn black and you're doing caries, okay, the decay will still turn black. It just won't turn back immediately. So the thing is that the decay will turn black if there's caries there, because it is the silver reacting to the light. So it's killing the bacteria, but it's reacting to the light. And that's why in, you know, a silver diamine fluoride, you're still going to get blackness if you leave that on the tooth. So what they're using in the States is a silver diamine fluoride, but it's a lower pH, and they're putting that on and then putting Durafat over the top. Yeah, it goes black, but because they can't leave it on there for 3 minutes and they're not adding the stannous fluoride, they need to do a couple of applications. The killer, when I say the killer, the thing that makes all the difference to the arrest and remineralization in CSDS is the addition of the stannous fluoride. It just looks very initially.
Thank you.
That's okay. And no other questions?
No, thanks.
Okay.
No,
All right,
thanks.
so,
Sounds good.
good. So if we're going to do this again next week, which I think is kind of fun, hopefully I'll have some more of those questions. If you have any questions of your own, email them in or put them on the, you know, the Facebook group, and we'll do that. And we'll also look at getting another case history going. Do you want to have a look at some hypermineralized teeth and what we've done with hypermineralized teeth?
Yes, please.
Okay, because it's very impressive. Okay. Dr. Craig and I are working on a paper at the moment with some of my case histories from what I've done with hypermineralized teeth, and it's so good. So I'm looking forward to having that getting approved and then published. So it's still a little way off, but it'll be good.
Kathy, I'd actually like some
They've both got pain.
aged care root caries.
Okay,
Yeah.
I can. Okay.
And I'll do another day.
What I will do in that, yeah, I know a couple of dentists that might be really happy to come along and help us with that,
99%.
and they can present theirs. Does that sound okay?
I'm sorry. Thanks, Huda.
Okay. All right. I'll try and get something aged care organised for next week if I can. Okay. All right. Well, have a good week. And if you've got any questions, give me just yell out, and hopefully we'll have the other ones sorted out also by next the ones from the EMS. We'll have those organised. Okay. See you all. Thanks for joining us.
Right.
Enjoy your cup of tea. Okay. Bye.
Thank you.
Thank you. Bye.